presentations virtually, but I've got a stand-up desk so I can move my arms around and I feel like at least I'm in presenter mode. So I'd be really excited if you guys can ask lots of questions as I go through this presentation, and as Gordon mentioned, for the Q&A part, I'll make some time at the end, if possible, for us to have a bit of a yarn. But my presentation is about Indigenous health outcomes and how they'll only improve when we have an Indigenous voice in the research that we do. And I will be providing a couple of case studies just to demonstrate what that looks like. And yeah, hopefully we'll have a fun hour. I'm all about fun, so hopefully, yeah, I can take you along that journey with me. And I might talk about the weather a bit too, Gordon, who knows? All right, but as is protocol, I would like to acknowledge the traditional owners of this land, Meanjin, Brisbane, and pay my respects to elders past, present and emerging, and the two groups, as Gordon mentioned, are the Turrbal and the Yagara people. But we have, I imagine, people from all over at least Queensland, but potentially Australia as well. I should have done my homework on this. So I also pay respect to elders past, present and emerging on those countries as well. Okay, so I'm just popping this map up here. So this is the good old AATSIS map that a lot of you have probably seen. It's not entirely accurate in terms of the language groups that you can see a little snippet of, but it does demonstrate how many different tribal groups we have across the nation. And so this is just a tiny little part of Australia, so where my family come from. So on my grandfather's side, we come from a little community called Gadooga, and Gadooga is just northwest of Lightning Ridge, and very, very small little, yeah, discrete Aboriginal community. There's been some really great people that have come out of there, including my uncle Michael, who was one of the first 4 Aboriginal peoples to establish the Aboriginal Tent Embassy in Canberra. And he did that by finding a loop in the legislation that actually said that you could camp on the grounds of Parliament House as long as your dwellings did not exceed 10. And so he and his 3 mates, and they were good looking roosters, they all showed up there with a couple of deck chairs, a little cardboard sign that said land rights, and propped for the day. But that particular site is on the grounds of old Parliament House now, and it's been there for 50 years. So I'm very fortunate that I come from a background of really strong leaders. And then on my grandmother's side, we are Cooma, and Cooma is actually this little pink bit up here. It goes over into Queensland. But this is my great-grandmother, my grandmother, and 2 of my aunties, and they were removed from Cooma lands and taken to Cherbourg Mission, and this photo is on Cherbourg Mission. And the reason I wanted to talk about this, just to start my presentation, is that Cherbourg is about 2 hours west of Brisbane, and it's a really small community. So there's about 1,200-ish people there at any given time from about 52 different language groups. And when I say language groups, that refers to tribal groups, or another way that we refer to this is countries. And so if you think about countries and you think about Europe, and you think about 52 countries with discrete languages, very different cultural ways of doing things being put together, it created a lot of disharmony. So, and the reason I'm pointing that out is because there's a long history of Indigenous communities like Cherbourg that have been subject to unethical behaviours and approaches by not only researchers, but also people coming in and running different types of support programs, and not always intentionally, but sometimes intentionally, the behaviours have not been the greatest. So in Australia, health and medical research has often been conducted on Indigenous people primarily for the benefit of the researchers, with little or no consultation or benefits for communities involved. This early style of research often adopted a helicopter approach, with researchers entering the community for short periods of time, collecting and taking data away with no further contact. This has over time lent itself to a mistrust of researchers by many Indigenous Australians. There are similar patterns in other countries where research conducted in Indigenous communities has not been shared with or returned to those communities. In some instances, research data has been taken, then subsequently used without permission, resulting in extreme breaches of trust. These experiences have left Indigenous people suspicious and mistrustful. In saying this, we as Indigenous peoples know that we need evidence-based practice and research to improve health outcomes. Initially, such initiatives as the Close the Gap campaign have also accepted that paternal types of research and initiatives have not been that successful and have this year relaunched or updated the Close the Gap campaign in partnership with Aboriginal communities. And they have finally acknowledged that the ongoing strength and resilience of working with Aboriginal and Torres Strait Islander people is going to be what makes this Close the Gap campaign actually be a lot more effective than what it is. So back to Cherbourg here for a minute. At the moment, there's currently about 94 research or programs being conducted down there. And a lot of people are not talking to each other. So think about a community of 1,200, 94 projects, research or otherwise down there, and yet the disparities in health, etc., are still really, really poor. And this is a community, like I said, it's only two and a half hours west of here. So, you know, something's not right. And so what I'd like to do today is just highlight how when you engage with Aboriginal and Torres Strait Islander peoples, you'll find that the efficacy that sits behind these communities is very, very powerful. And, you know, mob know what mob need, and through these collaborations, they will actually tell you what that is. So one of the most recent set of guidelines, and probably what I would say the gold standard in guidelines, is the NHMRC Guiding Principles to Ethical Research. And they are, oh look, I'm going to throw my notes away, I hate following notes. So these guidelines are awesome, but they're really about assisting you as researchers and working within that ethical space on committees, etc. They're there and designed to help and guide you in terms of when you receive a research proposal or whatever on your desk, that you can actually look at it in a critical way. And these guidelines really are there to flip the focus, I suppose, into an Indigenous lens. And so the things that we value in our community, and this speaks to every Aboriginal Torres Strait Islander group across the country, which is about, what have we got, about 250 countries or language groups or tribal groups, whichever way you want to refer to it. And within that, there's about 650 dialects. But we do have things in common. And one is we are a collective society. And so we choose to do things that are going to benefit the community more broadly than rather than ourselves. And the reason I note that is that in terms of the research that I have done, people sign up for what we do when they know it's going to benefit the community more broadly. And just as a little FYI, did you know that we are the only race of people in the world, and the oldest race of people in the world in terms of a continual culture up to 100,000 years, where we're a very flat structure. So we don't have chiefs, We don't have kings, we don't have queens, we don't have that hierarchical system. We're actually a collective society where everybody is there to benefit and support everybody else. And that's what these guidelines are really designed to represent. So we talk about what are we doing and what we're getting back, but it's very much a two-way process. And so that's really important. Building capacity is really, really important. So you want to see that research that's being conducted has an element of training or employment and things like that that go into the communities where this research is taking place. And even if it's a lab-based process and, you know, and highly clinical, it's still important that you give back, and easiest ways to do that is through educational programs, so through health literacy. And I've got a nice little example of that, which I'll show you a little bit later on. And can I just get a little thumbs up if you know about these ethical guidelines and codes of conduct? I actually can't see you all, but yeah, maybe Gordon, can you tell me?
We have 11 participants have raised their hands so far.
Okay, fantastic. How many are online?
154 so far.
Okay, all right. Well, hopefully more of you know about it.
Sorry, 37 have now raised their hand, and some are putting them down.
Fantastic. All right, and I'm sure you all do know about this, and it's a wonderful guideline. And I would argue that it's a guideline for all research, you know, like we're not, how do I say this? We're not different, you know, we are people who want the same things as everybody else in this country. And so, you know, it's all about just good practice. And I think that's what these guidelines really stand for. But they are very important when you are looking at research applications, just to ensure that that ethical responsibility is there. And if you've been around this type of research for long enough, you'll sniff out those that aren't very quickly, and those that are and have been working in this space in a genuine way. Oh, we've got a blank slide. Maybe I can talk about the weather here, or maybe not. All right. So the thing with working in this space is that we really need to appreciate that the communities are often key to the success of the research, and not often, I would say always key to the success of research. Nobody likes to have things done to them without them consenting back. Like, I would argue nobody likes that. And so when you're invited in, or when you are co-designing and working really closely with communities, you're always going to get better results. And so we've got here 3 primary features of Indigenous research: must include collaboration, mutual education, and acting on results developed from research questions that are relevant to the community. And that's pivotal, because if the community are involved in the design and the methodology of what is actually going to occur, then they're going to then show up to be involved in that. Conducting research in an Indigenous context is based on a mutually respectful partnership. And once again, this is just good standards. It's common decency. Partnerships are strengthened by joint development of research agreements for the design, implementation, analysis, and dissemination of results. And results of research are locally applicable. I think the piece I'm struggling with a little bit at the moment in terms of my own research is that dissemination of results. But you know, you can do a fabulous amount of work and you can present that back to the communities, and you know, and it's groundbreaking and we can make a massive difference. But then the next piece is, how do we then get that embedded into policy or into you know, into state and government agencies where they can pick up on this. So what I'm finding is you can do all this great research and get this great evidence, and then you go, hey, have a look at this, federal government, and they kind of go, oh, I think we'll need to do an analysis or a feasibility study on this before we take it any further. And you just go, oh my gosh. So I find it, yeah, that little piece is a bit frustrating. So if anybody's got some good ideas on how to lobby in that space, please put them up in chat. All right, I've got another blank slide. What's going on here? Okay, so I'm going to spend the rest of the time just talking about some of the projects that I've done. And as I've said to you, I am an Aboriginal researcher. My background is I didn't finish year 12. I dropped out. I was in the, remember those old year 12 yearbooks? Next to my photo, because my maiden name was Anderson, it said Maree Anderson, and underneath the photo, if you don't know who she is, that's because she's never here. And I was actually really proud of that. I'm not now, but I just didn't go to school because I was disengaged. I had really poor literacy skills as well, and there's a lot of reasons for that, which I won't have time to go into today, but I was speaking Aboriginal English, and like many of us do, many Aboriginal and Torres Strait Islander people speak a Creole, so it sounds like standard Australian English, but it actually isn't. And so when you try and write with that background, it's very difficult. So I dropped out. Anyway, long story short, I ended up doing a bridging program up in Toowoomba, USQ, and it was actually my grandmother's that did a major intervention on me and said, you know, you're going to university or you're doing something, because I was actually a grape picker in Griffith in New South Wales. And so that was pretty hard work and I hated it. So because of them, I started my educational journey. I was the first person to receive a PhD at the University of Southern Queensland in 2011, and I spent 10 years at that institution studying. So a year of the bridging program, then I did an undergrad as a teacher, went off and did that for about 6 years, came back, ran the program, the bridging program that I did. So I went back in and I was a coordinator of that. And anyway, long story short, PhD, and then landed within the Faculty of Medicine, which, yeah, was kind of an interesting transition. So, but that's a story for another day. But it was during that time, and it was 10 years ago that I started at the Rural Clinical School, which is a part of the Faculty of Medicine here at the University of Queensland within the medical program. And I was still based in Toowoomba, and we got a new head of school, and he was an endocrinologist from University of Melbourne, track record as long as 2 arms, and he darkened my door one day and said, "Are you Toomsy?" And I was like, "Oh, yes." And he goes, "I'm going to turn you into a researcher." And I kind of got a bit prickly, and I'm like, yeah, I'm not sure about this. And I said to him, "Well, what do you mean?" And he said, "Well, I've been working in the endocrinology space for a really, really long time." And he said, "And the disparities in health, particularly around kidney disease and diabetes and things like that, are through the roof." And he said, we need to do something about this. And so I pushed back on him and said, "Look, I think research is a bit of a dirty word and I'm just a little bit uncomfortable about this." And so we agreed that I would do a scoping driving trip. And it was actually a good excuse for me just to go back to community, to be honest. So I went out west, out to where my mob come from, but also went to places like Bogabilla and Toomala, which are 2 discrete missions just on the New South Wales side of the Queensland border, Queensland-New South Wales border. So yeah, the McIntyre River splits the states at that point there. And I just sat down and yarned with people, and we spoke about research and we spoke about where people thought that the need sat. And, you know, what was amazing about this is that people were not opposed to research. People understood that, you know, baseline data and evidence-based types of research projects were going to help them, and they really wanted to be a part of that, but they wanted to be a part of it, and that was the big point. And so what we found is that the main areas in which communities wanted buy-in was around primary health care, mental health issues, and as those mental health issues affected other comorbidities. So people were very clear and they could see that there was some major problems and major gaps in their healthcare, but not only that, access to healthcare. And the other area was around suicide intervention, prevention. So communities were really, really worried about their young people and you know, the rates of suicide that were occurring and still are. So Cherbourg, for example, has lost 7 kids in the since April. And, you know, like I've said, that's a very, very small community. So there was a lot of interest and also willingness. And so I said to these communities, look, told them about my boss, told them about what I'd been asked to do, and they actually gave me permission to do this. And so then I had this massive load on me to go and chase some dollars to try and deliver on the things that we'd spoken about. And so in 2013, I got my first lot of funding, and it was actually Health Workforce Australia, and it was to develop a mobile training facility, hence what you can see on the screen here, to reduce the rates of chronic disease in a remote or rural community or communities. And it was also to provide training for medical students, but also allied health students as well. So we got, it was $300,000, and for someone who had never got any funding, I thought that this was the bee's knees, and I had a bit of a strut going on, and I was like, oh my gosh, this is so cool. And so our first research project, which was really more about a capacity building exercise, emerged. And when I die, if I have that van and that Jeep somewhere on my gravestone, I'll be very, very happy. And the reason for that is, you know, and it's cheesy, but from little things, big things grow. All I did was go to communities, talk to them about this van and what we had, and then from that, the community did the rest. And so we called this van the MOB van, and MOB stands for mob, which is a term that we call each other, you know, hey mob, but it also stood for the acronym Mobile Outreach Boomerang, We Come Back. So we thought we were very clever. We engaged with local artists to develop the artwork which you see on the van. And what this did is it told the community that this was for them. So we then started to reach out again to communities to find out where we could actually take this to. And interestingly, and you're going to think, really? We ended up in a small rural community called Warwick. Now, Warwick is a really underserviced area. It was an area where we have quite a high population of Aboriginal peoples living there, and yet they were not visible in the community. And so when we approached local council to see if we could bring the van down, and more specifically the HHS there, we were told, no, you're not going to put this van on the grounds of the HHS because we don't have very many Aboriginal people and we think you'll be wasting your time. They also said that the only time they saw Aboriginal and Torres Strait Islander peoples down there is if they presented at an emergency department and they were acute by that stage. So We argued that there definitely was a big group down there and that this would be really helpful if they would work with us. So they said no. So in the end, we did get approval from the local council to place the van in the local park in the middle of town, which in the end worked out to be better because it meant that people could access it a little bit more freely. The hospital was sort of on the outskirts of Warwick. And so, yeah, but the proviso was that if anything happened to this van, it was on us. So basically it sat there as a sitting duck per se. So we set it up there. We had a doctor on board from Carbal Aboriginal Medical Service, which is a medical service up on the Darling Downs, Toowoomba, and it has a service area all the way down to the Toomala, to the Gundawindi, Queensland, New South Wales border at Gundawindi there, with about 6,000 clients that it services. So we had one of their doctors, we had an Aboriginal health worker, and we had a number of nursing students from USQ and some allied health students as well. And we set up shop. And on the first day, you could hear crickets. So we kind of had nobody. On the second day, we had an elder walk past on his walking stick and he kind of looked in, kept going. He did tilt his hat. And I'm thinking, you fellas better show up because you've told me that you want this. And so the next day, a couple of other elders walked past and gave us a smile, which was an indication that we were going to be okay. And after that, the clients came. And after 3 months, we had over 900 people accessing this van. And it was just like, are you serious? It was incredible. And at the end of the year, so we set this up, I think it was in March 2014. At the end of the year, the state government had heard about its success. And so what they did is they funded us $3 million for 3 years to see if we could turn this facility into a thriving fixed clinic. And so we were absolutely delighted with this. And what we did is we looked to lease a place for that duration of time. Unfortunately, once again, the council weren't overly helpful. And I will say this, it was really sad, but they offered us an old Queensland health building that was very run down and needed a lot of work, including like a ramp. So for people with walking, with disabilities. And so, and they wanted to charge us the earth. And on top of it, our clients weren't allowed to use the toilets in that facility because it was a shared space. So we were told that our clients could cross the road to the public toilets. And so for me, it was like, right, game on. And so what we did is we went and we leased the flashiest place in town. And it was this amazing 2-story facility with a glass lift. There was even a chandelier as you came out on the second level. And we kitted that out and we stayed there for a year. And it was during that time that we met a builder who was looking for somebody to lease like a building that he'd purchased and that he would fit it out for us. And so that's what you see on the screen here. And that's where we are and still remain out at Warwick. And so we currently have about 1,600 people that access the facility. It has over 23 Indigenous employees. So this is in quite a small country town. So 23 Aboriginal people's employed there. We've got 3 doctors. We've even got a dental chair now, but yeah, we've got to find a dentist. But it became part of Carbal, and here's me cutting the ribbon on the opening day. But one thing I will say about that van back in the park, it was never vandalised, and the community took it upon themselves to look after the van. So we had some major hailstorms, for example, that came through there, and the community went down and threw tarps over the van and, you know, basically sat by its side to ensure that it was okay during those periods of time. But yeah, I just, for me, that was the start of almost an addiction to this type of work. And I just think that I'm so blessed to do this stuff, and I actually get paid for it, like, you know, unbelievable. And finally, what we've done in terms of this particular sort of process as well is we've established an institute through CARBL as well. And it's there more by name than anything else at the moment because we're trying to get it up and running. But it's really about that evidence-based practice and research, again, being driven by the local communities for outcomes that they want. And so some of the main areas that have come up in terms of that is around hearing health. And so we've been conducting a whole lot of hearing health checks using that van, because you have to remember, we got a fixed clinic out at Warwick, so suddenly this van was sitting around not doing a whole lot. So it now spends its time going into a whole range of schools up in the Darling Downs area and doing health checks, and also 715s, which are a discrete specific item number for Aboriginal and Torres Strait Islander peoples and their primary health care. But yeah, we've got some great academics and researchers that are involved in this institute. And yeah, watch this space. Hopefully, you know, if there's will, we'll get this thing moving along. All right, so then, when was it? It was around about 2015. This was an NHMRC funded grant that I got. It was the second one. Once again, highly addictive when you get these things because they're so hard to receive. But this project came off the back of, you might remember at the beginning, I said that communities were really concerned about the rates of suicide in communities. So this particular grant was to build a tailored program. We call it gatekeeper training, but it's really about on the ground, grassroots ways of addressing suicide without having to refer people onto agencies. And so this is what the communities asked for. They said, look, kids don't want to kill themselves between the hours of 9 and 5. This stuff happens in the middle of the night, or we see early warning signs and we don't know what to do about it. So we spent a good year just going back to community, yarning with community about what they wanted in terms of a training program, and they were the things that they said. They had concerns about when someone was at risk of suicide, that they're often picked up by like ambulances or the police, and they were taken to hospitals which were sometimes away from their communities, and that often caused more trauma to the person and also to their families. So yeah, it was how can we support our communities within our communities, and so this is what we came up with, and the name of this program is called I Assist. We initially called it INSIST, and you know how NHMRC projects have to have lovely catchy acronyms. So it stood for Indigenous Network Suicide Intervention Skills Training, but communities didn't like it because INSIST to them sounded like incest. So there's some feedback from community that, you know, would never have crossed my mind. And so they had this aversion to it because of what the word was. So we changed it to I Assist. And I Assist is a tailored program that comes from an existing program called Assist. And Assist is a gold standard training program, one of the only gatekeeper training programs in the world. It was developed out of Canada, and we went about redesigning that to like purposely fit Aboriginal and Torres Strait Islander communities. And I have had a couple of people say to me, you know, why didn't you develop a culturally appropriate program that wasn't already developed, like, you know, why would you adapt a Western program? And my response to that has and will stand is that the word suicide did not exist in our language. The first time it was used at all in any of the literature, and even just yarning with people as well, was in the mid-80s. And so this is a Western disease. It's a Western problem. And so we co-designed and developed this training program to fit what suicide actually is. And so we've actually, our numbers are updated since here, but we've trained over 400 people in this program now. And the really nice thing about it is it's a social enterprise model. So what that means is that if you do the train the trainer component of this, then you can run your own programs and you're able to, you know, draw an income and work through different agencies to do that. And so the community really, really liked this idea. And the feedback that we've had on this has just been absolutely amazing. And just to go back a step too, and it's a bit personal, but I think, you know, story is important to us when we talk about research. But what happened to me and sold me on Assist is I went and did some training. So the Assist Train the Trainer program, because I got the money for this, but I didn't know what to do, you know, and I was like, oh, what do these gatekeeper training programs look like? So I went and I did Assist, and it was on the second day of that training that I realised that my brother was at risk of suicide, and I knew it, but I just had no idea what to do about it. And he was putting up a heap of stuff on Facebook, and, you know, whenever I spoke to him, he'd be like, oh, life sucks and I wish I was dead, you know. So he was saying some pretty clear things to me that were indicating suicide. And so on the second day of this training, where if you see here, there's a little model, this look, ask, listen, act. That's a very basic way of describing quite a powerful framework. But the look and ask piece and the listen and act was all about noticing. So I noticed that my brother was at risk of suicide. The training teaches you to straight up ask, are you thinking about killing yourself? Are you thinking about suicide? That's a really bloody hard thing to do, but you have to do it so that you know that that's what's going on. And so I did that. I asked him. He said yes, but interestingly, he said, how did you know? So often people at risk of suicide, they don't know that they're sending out like warning signs, or they're subconsciously trying to tell you. So when I asked him and he said yes, he just said he felt so relieved that someone had noticed. And so the next two parts of that is really about hearing story without judgment. And that's really hard, because sometimes you want to come in over the top and say, don't be stupid, you know, like, why would you say that? You've got all this family around you, but you've just got to zip it, hear story, but what you're doing is you're trained to listen for a life voice, so a hesitation basically, which thankfully he had, and then to act. And once again, this was about building that power, I suppose, in my brother to come up with solutions to how he could keep himself safe. And safe could be for 5 minutes while you ring an ambulance, or safe might be until he goes to see the doctor. But it's just an incredible program. And I just want to show you a couple of different workshops that we've done. So this one here was up in the Northern Territory, so up in Darwin. And these mob come from all over NT, and some from some really, really remote communities. And they used this tree in the background. They used a lot of their own like places and spaces to help describe suicide and parts of the training up there. So we've really developed this program to make it a localised way that communities can actually, attach themselves to it, so give meaning to where they're from. This lady here, far out, gave me the hardest time in terms of how much community capacity building I'd done and so on. And in the end, she was the biggest advocate for it. So yeah, she was pretty cool. This one here, we ran up in Rockhampton. And one thing I will say, every single workshop and every single person that came to these workshops had a lived experience of somebody who had taken their life, so within their family, or they had had their own experience as well. And I won't point her out, but one of the members of this group had lost 2 of her own children and 2 grandchildren, and she did the training and she just said it just changed her life because now she knows what to do. So, you know, once again, I get paid to do this stuff, seriously. It's just, yeah, so inspiring and exciting when you see the light bulb go on and people get it. And here, forget the van, but the rest of this here shows the actual processes that we did to get where we are. So these 2 girls here are both actors or actresses. And so they form part of some filming that we did around the training process and for the training videos that come with iAssist. And it was a bit of a family affair because we did the filming in Melbourne at my brother's house, and we had a big, yeah, filming crew, and anyway, it was very, very cool. And then these guys here also at an acting school in Brisbane, and they took the training and did their own interpretation of how they thought that the training should look. And it was beautiful because they're all young people, and you know, some of them off remote communities as well. And so they were able to assist us in how we should develop the training as well. So yeah, we really engaged till the cows come home. And I just want to point out this woman here. She has recruited more people, I think, than anybody else in Australia could. I'm going to put it out there, but anyone else in Australia could in terms of the projects that we've done, because she's grassroots, very, very well connected in her community, but also a number of others. And then she knows people from other communities. So through her, we've recruited, I would say, at least or over 1,000 participants for the research that I've been involved in. So this is one of 3 projects that I lead. So yeah, amazing woman. All right, how are we going for time? All right, we've got a few minutes. I won't show you this video, but I'll just quickly talk about it, and then hopefully we might have time for a few questions. But this was a project that I was involved in. It was led by a guy called Greg Pratt from QIMR, which is here in Brisbane. And it was really another conversation piece. So what he and his team did is they worked with people like myself and other Aboriginal academics that sat in different locations across Queensland. And he took a conversation into these communities, which we helped facilitate and were involved in our region, to talk about genomics and informed consent and how communities viewed what that looked like. And so it was really, really interesting. What I found with this is that communities were happy to be involved in genomics and to give blood and all these sorts of things that I thought were quite taboo, but they understood that this is the way that we're moving forward. But there needed to be a lot more training and literacy around what this actually meant. And so some people understood it, others had issues about, well, what happens to our blood when you take it away from us, you know? So there was a whole lot of that, because culturally when somebody dies, everything of them must be buried with them in terms of their body. So there is a place in Canberra, so it's the Indigenous Genomics Centre, where bloods are stored and they can be returned back if the family request it. So it was just amazing. But what came out of it was this really cool little video, and it's Your Blood, Your Story, it's called, and it's just an awesome way of telling people what genomics is, and that your blood tells a story. And that came out of the feedback and the guidance of communities all over Queensland. So once again, yeah, I just think that's awesome as well. So I hope you do, because I'm like thinking this stuff's just amazing. So I hope a few of you are going woohoo as well. So maybe not. But anyway, the other thing is informed consent. There are some really good training programs that you can do, so some online stuff as well, just to be sure that informed consent is informed consent. And I can say that when I first started in this area, I didn't really understand what that meant. And so, you have this really big ethical responsibility to not only explain the research, but ensure that you're explaining it at that level that the community do understand. So I think if you get that piece right and you get the community capacity piece right, and you find out who it is that you need to connect with, you'll find that your outcomes will be really, really good. And there's my Margie again, and one of the psychologists that was on another research grant. And these are those ethical guidelines that I mentioned from NHMRC. So the reciprocity, respect, equality. That survival and protection is really about how do we support mob in, being healthy and living longer lives. And then the responsibilities back on the researchers and I would say ethics committees as well, because you guys have got the power. You can pull stuff up at that point and say, we want some more information. And please don't hesitate to do that, because, yeah, you can be the difference between something being, wonderful and great and something being really, really quite harmful to Aboriginal people. All right, that's it. That's me. So how are we going? We've got about 12 minutes left if we want to have a little Q&A, or you want me to talk about the weather?
No. We don't need the weather. The weather's, the sun always shines on a Friday, Maree. Look, as always, inspiring and so important to hear about how to do research. It's, I speak as an ethics committee person here, and we largely don't know what we don't know, and we feel our way around, and irrespective of using guidelines as good as they are, sometimes it's difficult. I know in my UQ committee we have one of our members has worked in Cherbourg, and so is able to provide a lot of guidance there, but still, I think it always leaves us wondering about how we can do better. Yeah. So a few questions anyway, and let's see how we go with these. First one from Michelle Cameron, which is a great question. And Maree, with respect to research that can be done to death, let's say, so research projects that might be done in Cherbourg because it's 2 hours away from Brisbane, is there a register of research projects that occur in Aboriginal communities? And how do we? Is there a responsibility on ethics committees to moderate the amount of research that gets done there?
Yeah. So sorry, who asked that, Michelle?
Michelle Cameron.
Yeah. Thanks, Michelle. That is a fantastic question, and there are no registers, and it highlights a major problem that we have. So when I mentioned those 94 projects, nobody's talking to each other. And what's interesting is sometimes they're the same type of projects as well. And you kind of go, like, there might be 3 teams down there doing work, Titus Media, or there might be, a mental health team down there. No one's talking to each other. And so, it makes it really, really difficult to get good work done. I've found, I'm going off a little bit on a tangent, but I'll get to my point. With this role that I have as Associate Dean here within the Faculty of Medicine, I did a big scope of what research projects are across the university that are specifically tied to Indigenous health research. And we've identified over 50 projects. And what was fascinating about it is some of the researchers said they didn't consider themselves to be working in Indigenous health, and yet they were. And so it was almost, I don't know, they were devoid of this understanding that when you do play in this space, there are responsibilities and great people. Like, I'm not bagging anybody out here, but it probably goes back to your point, Gordon, that people don't know what they don't know. And then for other researchers, you know, you could have 2 people or 2 research groups on different levels of one of our big research facilities who are almost doing the identical thing, and yet they're not talking to each other, you know. So what we're trying to do at this level is bring these teams together and look at ways that we can do this. I mean, we can certainly make changes within this faculty, because that's exactly what I want to do. And Michelle, it goes back to your point about a register, about identifying and understanding who is doing what. But in terms of the ethics committees, I think that you guys could certainly play a large part in how this transpires.
Thanks, Maree. Look, you know, my first introduction to Aboriginal television, I suppose, was the film Walkabout, you know, back in the 70s, and leave that one there. But Jenny Agutter, I was thinking, but anyway, there was a scene in it where I think the young Aboriginal man committed suicide. And I guess I just wanted, just out of curiosity, and maybe others are interested, how do Aboriginal communities, how did they conceptualise suicide before it was essentially became that sort of Western construct?
Yeah, that's a great question. So that group I showed you from the Northern Territory, they developed their own training video to take into these really remote communities to explain suicide. And so in the work that they did, they show a spirit of a young man who has taken his life, and the spirit of the young man is talking to the young man's best friend who's sad and contemplating suicide himself. Okay, so it's spirit talking to this young man, and how the young man, along with his uncles and his father, recognise that this spirit is actually a bad spirit. So they played with that to describe what that actually meant, and that, you know, the boy who took his life would have wanted his friend to have a long, productive life, and so that was a bad spirit. And so that's how they described it, and it's been really powerful, because there's a contagion. So what we see is in a lot of these communities, a child will take their life, and then, you know, a number of others will as well.
Yeah, that's a tough question. Thank you for answering that. So I suppose in the same line, and there are some other questions, and I'll get to them. I'm just a bit curious myself. Are there any areas of research that you would consider to be still taboo? And by which I'm just trying to understand how, as ethics committees, we can, you know, I don't want to be paternalistic, and we don't want to be paternalistic. It's just, how do we deal with things? You know, obviously we want to get views, but in your view, is there anything that's still taboo?
I think the 2 areas are suicide. A lot of communities are still very funny about that. It's, you know, we don't use that word, and A, because it didn't exist in language, but B, this idea that if you talk about suicide, someone might do it. So that is certainly an area. And how you would deal with that is always looking in those ethics applications for strong connection with people in those communities, which give evidence that they're supportive of this. Okay, so if someone's going off into Timbuktu and you can see no engagement, or there is no letter of support, then I would be asking for those sorts of things. And then the other area is in genomics, and that's because, you know, our blood has been used in the past against us rather than for us. So it's once again ensuring that there is that piece within the ethics application that describes informed consent, describes that either there's already an established relationship and these conversations have already occurred, or that there's going to be a major piece of that consultation process before it happens. And I mean, I don't know if ethics committees can do this because I'm probably expecting you guys to fix everything, but, you know, the other piece that's missing is how do you know that they've done it? You know, there's that follow-up piece as well. Like once there's the tick, off people go, and you just have to, you know, assume that they're going to do the right thing. So there is an integrity piece to that as well. And I'd like to think that we all have it. But yeah, I just think that checks and balances is great.
Yeah, look, you raise a great question there about oversight of research, and it's too big for this session, but it's a very important point. And as you mentioned, Greg Pratt, and of course Greg has done some great work in this. And I know Simon is still down in ANU, he has that Aboriginal, I think blood and DNA collection, and I think now that has been put under curation appropriately. Moving on, Maree, this is from Indrani Ganguly. Indrani sits on my UQ Ethics Committee. Do you have training programs for researchers who are part of your teams, but not from Aboriginal backgrounds?
Yeah, absolutely. And once again, it goes back to you don't know what you don't know. So I'm trained as a facilitator in cultural training practices, etc. So I run those for lots and lots of groups of people. I probably shouldn't have said that out loud, but I love doing it. And the reason why is because everyone that's sitting here in the room today, your history is Aboriginal history as well. Like we've got this beautiful, beautiful culture here that goes back 100,000 years, and we need to all know what that's about because it's fabulous. And I think, yeah, any opportunities that you get to do training, like I do highly encourage it. There's a great training group here in Brisbane called Black Card, and they run some great training as well, but it just helps you to understand like who we are and you know how we kind of operate in terms of our cultures. Yeah, so I'm not sure if I answered that, but yeah,
I think you did to some extent. I mean, you know, I've certainly been trying to have cultural capability and cultural awareness training done. It has proved a bit challenging. Just timing is tricky, and I think there's a great need for it. And you know, there's sort of a waiting list. So I think there are opportunities around, and I thank you for mentioning Black Card. I think that's a great point. Now, from Yates, and I'm not sure if it's a Yates that I know. My question is, do you think there's a way of streamlining ethics approvals so that if local Indigenous people are wanting research done, there are less layers of approval needed?
Oh, yeah. Look, I think there are better ways of streamlining for sure. I'll give you a really great example. So Inala Aboriginal community, which is just down the road from here, they have a Aboriginal and Torres Strait Islander jury. And so what they have there is the researchers go in and they present to this jury of Aboriginal elders and stakeholders who approve or don't approve research. And they'll often send the researcher away and say, come back with A, B, C, and D, and then we'll have another yarn about it. But that process irons out all the creases, and then, you know, with those sorts of processes, if you know that an ethics application and a research project has been through a really stringent process like that, I think that that would then make your job a lot easier. And what also happens at that point is it irons out those projects that the communities don't think are going to be feasible.
And it's a great point, Maree. And yesterday we were sort of having a discussion about the community involvement in applications, not just for First Nations peoples, but generally for any people, because unless you use the correct people to give you advice, you'll never target the research correctly. And I think it's a great segue, because I think it shows that most ethics committees, although they may have some Aboriginal members, they don't necessarily represent the whole, Aboriginal community, and therefore seeking input from the appropriate entities such as ANALA may be the way forward.
Yeah.
The Yates, who asked that question, said, there have never been any concerns about the actual research, only about ticking all the boxes. And to be honest, this has put me off wanting to research in this space again. And I think we would all agree that there's a heck of a lot of box ticking. Our job as ethics committees is to add value and protect participants. How we best do that without the layers of bureaucracy is clearly what we have to try and achieve. In your opinion, should an ethics review be provided by the geographically closest ethics committee to where the research is going to be implemented?
Absolutely, but I think we know, particularly here in Queensland, that we don't have them everywhere. So yeah, like I think you guys, you pick up a lot of the research ethics from up north, hey, because there isn't any ethical research places up there.
Townsville Ethics Committee is certified to do that. Metro South are. We do, by virtue of the fact we have a relationship with Queensland and Aboriginal and Islander Health Council. Not every ethics committee does, but it is quite a good question. And just to take it slightly further, do you think it's more important to use the relevant community to provide you feedback, or the ethics committee?
I think the relevant communities, and like we've got, and you guys have got access to this, just speaking locally here, but we've got a whole heap of honorary appointments that sit within our uni of very learned Aboriginal academics that would welcome the opportunity to review these ethics applications. So, I mean, a recommendation for me would be to set up some governance groups that sit across these locations, giving community members an opportunity to do what the ANALA jury do. It'll save you a lot of heartache, and it will also, you'd almost kill two birds with one stone, give people an opportunity on those governance committees to be engaged in what's actually happening in front of them.
Yeah, that's a wonderful answer. Now, Maree, I'm just going to keep going. You've probably got about 5 or 6 more questions. And as long as you're happy and the audience is happy to last till about 10 past, I think it's just so important we get these questions out there. Do you have any collaboration with First Nations people from other countries?
Yes, I do. So I work really closely with First Nations community in Canada. And I'm actually on a big Canadian Institute of Research grant, a CIR or CIHR or something, but equivalent to NHMRC. And it's around genomics. So we're doing a national yarning across Canada in terms of what their viewpoints are in genomics within their community. So I work really closely with crew over there, particularly on the East Coast. I've got an adjunct appointment at Dalhousie Uni, which is in Halifax, Nova Scotia. And then the other project that I do over there, which is a private NHMRC funded project, is we're looking at it's a RCT, to develop an Indigenous mental health model of care to reduce depression rates in Aboriginal peoples, because they're about, through our research, about 4.5 times higher than the national average. And we're working with traditional healers in that, so referred to as Nunkari in some states. But we're doing that also over in Canada with First Nations people, predominantly from Winnipeg in Manitoba, right across to the East Coast.
Wonderful. So Ben Kenny asks, Maree, could you please comment?
Hey! Hi, Ben. Sorry, I know Ben.
And Ben's on this afternoon on the HREC chair panel, so you can come and ask him some questions. Could you please comment on how we can use the guidance on working with Aboriginal and Torres Strait Islanders to inform our interactions with other communities? or do you think they might be more specific than general?
Okay, good on you, Ben. That's a curly one. No, I think it goes back to my point right at the beginning of the presentation that, you know, those guiding principles that we refer to in terms of the NHMRC guidelines, you know, they're best practice for all research. And, you know, we've sort of had this conversation through today's presentation about how we can engage in other communities, other minority groups. And I will say that with the preface that we are the First Nations peoples, so we're a minority within Australia, but we're not an international minority. Just in case I've got Aboriginal listeners out there, they'll have a go at me about that one. But yeah, it's about just common decency and best practice. You know, nobody wants to have stuff done to them. They want to be included in that process. So I think a lot of this is common sense. You know, I often get these wide-eyed people going, you know, how do I engage with Aboriginal people? And they've got their pen and their paper out and they're waiting for me to give them all the answers. And I'm like, just be a nice person, have some integrity, communicate, you know, like just be, and that's all this is about. It's not rocket science.
No, and I think we speak the same language in regard to all research. Maree, this is from Benna Brown. Benna's, hello Benna, thank you for listening. Benna's on another committee of mine. Wondering if you can expand on your experience using technology in rural and remote communities. What is the access to technology like? Yeah,
great question. And this blew my mind. So that mobile app, you know, that image that I had going back a bit, that was part of that iAssist grant. And I kind of bucked a little bit at this idea of introducing a mobile app into communities. And that app was designed to support people who had done the iAssist training. And anyway, it had all these functions in it. Mob went nuts for it. They absolutely loved it. And I argued that that wouldn't have been something that was picked up on. But because it was a tool that they could use and the tool could help them save lives, it had a geolocation on it too in terms of what services might be available in that area. It prompted them to help, prompted them to remember how to do the actual steps for the suicide intervention. But most importantly, what the community loved about it was set up as a networking device. So people who had done an intervention, so they could then contact somebody else that had either done the training with them or was in their local area, you know, just to kind of get on this app and message and then exchange numbers to go, oh my gosh, this is what happened. And they were able to debrief with each other. And so, yeah, I think they have their purpose when they are a tool that's going to be useful. I've seen some of these types of apps that haven't been that successful, but once again, we spent a good year communicating, collaborating and designing that app with community until we had it how they saw it as being something that was going to be useful for them. So I hope that answered your question.
No, thank you for that. I mean, it clearly to do research that requires technology, you know, you have to have access to it to do it there. So I think I did answer the question. Maree, we've got 2 minutes left. So in a population-wide genomic study, which includes Aboriginal and Torres Strait Islander participants as well as others, should ethics committees request specific considerations for blood and DNA collection from Indigenous participants?
I think that comes down to that informed consent. So I would argue that within that consent process, participants are made very aware of where and how that blood is stored, and that people that are working in this space with Aboriginal, you know, people and their genomes and bloods and samples utilise that institute, the Indigenous Institute of Genomics, which is based in Canberra, because that's the only way if something goes wrong and that participant or their family want those samples back, that would be the only way I would argue to get them back in a timely fashion, because that institute is set up to do that.
And I think that answers another question asked by Neil, which was any advice on the participant information sheet. And I think, Neil, the issue is one has to be incredibly specific about what you're trying to achieve and provide the information that's required. And so I think, if I'm understanding you correctly, Maree, the information that you provide in relation to these things must be incredibly clear and specific and take into account the cultural considerations that you've discussed.
Yeah, and use that YouTube clip that I put up, the Your Blood, Your Story, that was developed by QRMR. Like, that will explain very, very clearly in layman's term what genomics is, and once people see those sorts of things and they understand it, because one of the things you've got to be careful is sometimes we get what we call Mr. and Mrs. Noddy, but people are going yes to you when they actually don't understand what you're saying, and it's one of the things you do have to be careful of. And so and we pitch our consent forms at about a grade 8 level, and so that's considered to be the standard for all research, actually, in terms of that consent. But if you can think about the language that you use, and there are functions that you can use within Word as well, where you can readjust your language to that level, then that's really helpful. And we have competitions within our groups on how quickly we can get that done, and so you can make some fun out of it as well.
Maree, every ethics committee member online will be saying the same thing here. How do we make our participant information sheets, as incredibly simple as possible? Because right now we have these 7-page, 10-page, 20-page things, and realistically we don't need that much. But the question is, how do we get them smaller to make them specific for those particular research studies? So one of our speakers the other day was Tanya Simons is doing a project to try and make them smaller. But again, I think these things have to be done in cooperation as a co-design project, and rather than internally. Tanya, we're going to stop there, I think. One final thing, Simone Reynolds did ask, which informed consent slide were you referring to? Did you have
it wasn't an actual slide. It was just where I put up the genomics link for Your Blood, Your Story. So I didn't provide a slide on that, but I could find something and send it through as an example if people were interested in that.
Yeah, and I mean, if you're willing to either allow us to publish this presentation online, then attendees can actually look at that presentation, and there's no need to provide the slide. Now, Maree, that was wonderful. It was an awesome talk. So I'm just going to try something. I'd like all participants, please, to raise their hand in admiration of Maree's talk. Okay, we're up. Come on, I need 168 here, please.
Whoa.
We're up at 78, 80, 90. Come on. Everyone should know how to use the technology. Well, look, we're just about to crack the 100. We've cracked 100, so that's 100 out of 100.
Thank you, guys.
and the comments. And Gary Allen on the sidebar attendees has put up the link to the YouTube channel. Thanks, Gary. The comments on the chat, Maree, have been just outstanding, and thank you for your presentation. So on behalf of everyone attending, it was just a wonderful presentation. I love listening to you talk. It's just makes you realize how simple things really should be. Yeah. But sometimes I think we can overcomplicate it by, as you say, being a bit too tentative and looking for something prescriptive, when in actual fact it's really just about a conversation.
Yeah, exactly. There's a saying, there's not a lot of common in common sense. So let's get common sense back on the table.
Common sense is wonderful. Okay, so with that, Maree, thank you very much for your presentation. And